Right, good evening, ladies and gentlemen, esteemed colleagues, to everyone joining us from all over our beautiful South Africa. I'm proud to announce that the registered viewership for the meeting tonight is in the order of about 280 participants, and I wish to extend a warm word of welcome to everyone. Thank you for taking the time off from your commitments to your families, perhaps leaving work early or perhaps even staying on at work in order to join us tonight. I wish to use a minute to thank a few special people. To our wonderful speakers tonight, Dr. Amanda Egan and to Dr. Vaneshri Naidu. I will introduce my two colleagues in just a minute. Thank you very, very much for your willingness to do these talks and for all the hard work that you have put in during the preparation stage. Just to quickly introduce myself to the audience members. My name is Piet Swanepoel. I'm a histopathologist and I have been with AMPATH since 2008. Firstly in Nelspruit for about 6 years and thereafter in our East London laboratory for nearly a decade, where a big part of my heart still remains. I moved up to Gauteng in January this year with my family to take up the role of regional managing pathologist for the northern region in AMPATH. We as family rediscovered Highveld winters, which came as a bit of a shock to us all, and record-breaking load shedding was not making anything much easier. My involvement tonight is in the role of anatomical pathology peer group leader for AMPATH. I wish to thank all my AMPATH colleagues who are also joining us tonight. I feel truly blessed to be surrounded by people of this caliber, and we do genuinely appreciate the support tonight. Thank you very much. This event forms part of our cervical cytology campaign, which is a joint initiative from anatomical pathology and AMPATH marketing. With that, I want to just make it clear that the speakers tonight, including myself, are all anatomical pathologists. Our collective expertise is that of microscopic morphology, that is cytology and histology, so none of us are experts in anything related to virology, despite the fact that you will hear quite a lot about human papillomavirus infections tonight. The aim is to simply, to simplify the topic, I guess, more for ourselves, and we want to demonstrate the overlap in the use and the supplementary nature of pap smears and HPV testing to screen and triage our patient population, and the intention will not be to play the one discipline off against the other. On this front, we were also kindly assisted by our team of virologists during our preparations for these talks, so for that I also want to thank you very, very much. Cervical cancer is a massive health problem worldwide, but especially in our part of the world, as you know. Over 90% of squamous cancers, in other words, invasive epithelial malignancies that in most cases produce keratin to some degree and show a lineage of differentiation towards the cells of the ectocervix, as opposed to the adenocarcinomas that show some degree of gland formation and mucin production. In my experience, a 90% figure in the international literature does not hold true in South Africa, as our rate of squamous cancers versus glandular cancers of the cervix far exceed the 90% mark. Nearly all cervical cancers are caused by HPV infections, as you know, through a set of precursor lesions. The high-grade squamous intraepithelial lesions should be regarded as true non-invasive pre-malignancies. Internationally, HPV 16 and HPV 18 are the viral types mostly implicated in malignant transformation, although the South African reality is again slightly different. I will talk on this in a minute. It is important to know that not all squamous carcinomas look the same. There is a spectrum of morphological patterns and variants, as well as different grades of differentiation. The topic is quite complicated. This is a very good reference article that discusses global trends, and I wish to show just a few graphics that are published in this work. It represents WHO data. This is information that is well known to us all. Cervix cancer is a very big problem in Eastern, Southern, and Middle Africa, and it does indicate to us that cervix cancer is a disease associated with socioeconomic challenges and the relative unavailability of healthcare resources and screening. When you look at the incidence of cervical cancer diagnosis on the left and then cancer-related mortality on the right, you will notice that we are, in a way, outperforming the other high prevalence areas in Africa. And I can only guess that this is because our screening programs, although not as effective as in other parts of the world, and our ability to more effectively treat these patients are better than, let's say, Eastern Africa. And therein lies the crux of the matter. Screening and early diagnosis is absolutely crucial in achieving better outcomes. Just quickly, 2 slides to demonstrate the worldwide burden. Firstly, of cervical cancer diagnosis, this blue slide. And the red slide, a similar heat map indicating mortality from cervical cancer. I don't think we have to say it again, as one should never repeatedly state the obvious. With a few exceptions in the rest of the world, this is a predominantly local problem. By local, I mean sub-Saharan Africa, and therefore we require local solutions in combating this disease. Now, if you look at the National Cancer Registry, of which the latest edition was published in 2019, cervical cancer is the second most common malignant diagnosis in South African women behind breast cancer. But amongst our Black population in South Africa, it is the most common malignancy. And I know that the writing is quite small, and I apologize for that. As one studies the age of diagnosis in terms of 5-year categories, one almost gets the idea that it continues to occur earlier and earlier, with significant numbers of cancer cases being reported in the age group 30 to 35 nowadays, and even younger than that. And I think it is fair to conclude that the HIV epidemic is probably the main driver of this phenomenon. The search for solutions has a very long and very interesting history. This is a beautiful photo of Dr. George Papanicolaou, who is credited with being the father of cervical cytology. What many thousands of researchers have found subsequently, going as far back as the 20s, was that there was correlation between the morphology of the individual cells on vaginal and cervical smears, the histology of the lesions, and clinical outcome. Just using a few examples, here you can see the classic Guilocytes on both cytology on the left and histology on the right that implies an active HPV infection. These cells are characterized by pale cytoplasmic halos and relatively mild nuclear enlargement. Please compare the abnormal cells on the top to the normal squamous cells on the bottom of the left-hand picture. This represents the low-grade side of the morphological spectrum. On the opposite side of the spectrum is a clearly invasive cancer, as seen on histology on the right, and very ugly cells on cytology on the left, with severe atypia of the nuclear features and spindle cell forms with ridge, or should I rather say eosinophilic keratinized cytoplasm. But please remember that these premalignant changes fall along a spectrum of abnormalities. So I want to take you back to your 3rd year pregraduate pathology. Here you can see normal squamous epithelium on the left, and the second slide, atypical or dysplastic changes of the basal layers representing a CIN1 lesion. Then on the third picture, with dysplastic changes affecting the basal 2/3 of the epithelium in a typical CIN2 lesion. And lastly, full thickness dysplastic involvement of the picture on the right in a characteristic CIN3 lesion. Also be reminded that these CIN lesions, which stand for cervical intraepithelial neoplasia, are to be used in reporting histology, whereas the SIL diagnoses, which stand for squamous intraepithelial lesions, are used in cytology. Low-grade squamous intraepithelial lesions is a collective term for HPV infection and, at least in theory, CIN1 cytomorphology, and high-grade squamous intraepithelial lesions is a collective reference to CIN2 and CIN3 lesions, but again, only to be used in the context of cytological reporting. And if I can just quickly describe what these CIN3 cells look like on cytology, and what we then refer to as a typical HSIL on the right. Relatively small cells due to loss of cytoplasm, larger nuclei which result in a very high nuclear to cytoplasmic ratio, with deeply darkly staining and somewhat clumped chromatin, and with very irregular nuclear borders. Having shown you these beautiful photos, as a traditionalist and a warm-blooded histo and cytopathologist, I must confess my love for this field of study, as the morphology of the cells, in my mind at least, is very predictive of the state of affairs, and the cells are, in a very strange way, beautiful to look at. Almost as if they are speaking to the pathologist and whispering words of wisdom. And the danger then is also that we as anatomical pathologists might choose to remain to live in this world of morphology alone, whilst we know that there is much more to the topic of cervical carcinogenesis. Which then brings me to HPV infections as the underlying cause of cervical cancers. I'd like to refer you to this wonderful paper on the topic of HPV prevalence in South Africa, which they not only demonstrate that yes, HPV 16 and HPV 18 are the main culprits, but that many other HPV types are involved. And in many cases, one actually find a combination of HPV infections in one particular individual. I want to quickly say something about the HPV genome. I'll keep it very simple. I'm not a virologist, but keep in mind that this is a living organism that is, like most of us, instinctively interested in replication in some or other form. So it has a fairly simple set of early and late genes with protein products that have very specific functions in terms of replication of itself by infecting human epithelial cells, using its own and the host cell's machinery to make copies of itself, package all the material into new baby viruses, and then shed this wither cell on the surface of the epithelium in its millions. Please take note on the top of the E2 gene, which, as I understand, tightly regulates the translation of E6 and E7 on the right-hand bottom in a very controlled manner. The E6 gene product, by function, inactivates and or degenerate P53. Now, P53 is like the policeman of the cellular DNA. So normally P53 will stop all replicator functions in a cell when it picks up genetic mistakes and allow the repair mechanisms to kick in. But once it realizes that the cell can't be fixed, it will force the cell into self-death, in other words, apoptosis. So a dysfunctional or a deregulated P53 will tip the balance in favor of malignant transformation. Similarly, also in a complex way, the inactivation of the host cell's retinoblastoma gene by the viral E7 protein product will, in combination with E6, push the cell in the direction of malignant transformation. It sounds strange, but this highlights the importance of a healthy and intact HPV genome, if you were to get one, in order to avoid a molecular genetic disaster. So what research in the last few decades has shown is that in cytologically low-grade lesions, the HPV infections are usually transient. In other words, they clear over a matter of weeks. And typically the viral DNA is polyclonal, normal or intact, and the viral E6 and E7 are under the normal control mechanisms and not overexpressive. But in cytologically high-grade lesions or cancers, the HPV infections are typically persistent and monoclonal, and E6 and E7 are overexpressed, leading to host cell deregulation and increased proliferation. In these high-grade cases, the viral DNA has been integrated into the host cell DNA, which should be viewed as a serendipitous event on the part of the virus, effectively ending its life cycle, but at the same time creating a hybrid monster, which is the host cell with acquired malignant potential. And what actually happens is that there is a break in E2, resulting in the loss of its normal regulatory functions and integration of the viral DNA into the host genome at this particular breakage point, in such a manner that E6 and E7 are then free to translate into proteins without some form of downregulation, and I believe also under the proliferative machinery of the host cell. From what I understand, the so-called high-risk viruses are then more likely to undergo this process of viral genetic integration compared to the low-risk viral types. So simply put, we have two major tools in screening patients as part of our risk assessment exercise. One is morphology, in other words, pap smears, and the other is HPV testing. And to me, both methods are like sophisticated but quite different home security systems, and I wish to explain this as follows. In the weirdly abnormal interaction between, let's say, valuable property and a culprit, cytomorphology will tell you what the damages are, and by implication, the effect of the insult. And HPV typing will tell you more about the inherent nature of the culprit. So to use this analogy, a cytologically low-grade lesion will be similar to be alerted by your security company that someone appears to have jumped your gate and stole the hosepipe. A cytologically high-grade lesion will be reported as broken windows with obvious signs of home invasion and a missing TV or stolen jewelry, whereas the cytological diagnosis of malignancy will probably be similar to being alerted to home invasion and homicide, which you may correctly argue is good information to have, but too late. Continuing with this analogy, HPV confirmation of low-risk viral type will be similar to being alerted that there is a local scoundrel sitting in front of your house on the pavement. You will start fearing losing your house back through your fence, but nothing else of real consequence. And a high-risk viral type will be, in a way, being alerted to the fact that a vicious-looking person with a long criminal history of violent crime was noted at your broken front door carrying a machete. I feel that I would like to have all of this information at once, but I can see scenarios in which one form of alert might be favored over the other. And for these reasons, we will now ask our guest speakers to tell us more about it. I trust that we are now all comfortable wherever we are, so may I ask for Dr. Egan to start with her talk on the art that is cervical cytology.
Good evening, everyone. I'm Dr. Amanda Egan. I'm going to discuss the area of liquid-based cytology. So I'll be dealing more with the morphology aspect of what Dr. Pete Swanepoel just made a reference to. I would like to make an introduction to my talk using the Bethesda system for reporting cervical cytology. This is the universal language of cytopathology, meaning this is the system or the reporting system used worldwide, and it's there for various reasons. The most important is basically to bridge the gap between cytopathology and the way we speak, and just to how to relay that information to clinicians so that they're able to manage their patients accordingly. There's no point sending out a report that makes sense to us, but not to the clinician, because I think at the end of the day, you all clinicians want to know what to do with your patient. And that's one of the main reasons for the Bethesda system. It also bridges the gap between the different laboratories and how we report things, so that everything is standardized in a way that makes it easy to assess, easy to read, and easy to interpret. It also is important in terms of updating the terminology, because, as Dr. Pete Swanepoel has said, cytology is moving more into a very futuristic domain, and we are starting to deal with things which would need to be clarified, and we would need to update the previous terminology that was used before, come up with new terminologies or new ways of explaining to clinicians what exactly it is we're doing, what we see with the pap smears, and how they need to manage their patients. So with the Bethesda system, what we do look at are a few things in terms of assessing the specimen. What type of specimen do we have? Now, there's a conventional pap smear, and then there's the liquid-based cytology, which is what I would like to go into. The conventional smear, most clinicians would already have come into contact with and have probably used this method throughout their career. Whereas with the liquid-based cytology, it's a little bit of a new thing for some clinicians. Some clinicians have been using it, which is great. And I'll basically try to let you know why liquid-based cytology is the future of cytopathology. Not to say there's anything wrong with conventional cytology. It's just this is a form of progression in the cytopathology world. In terms of specimen adequacy, we would also need to assess when we look at a specimen, is it adequate enough for assessment? Because at the end of the day, we can't give a result that is on a specimen that is not adequate, because that would be doing the patient a disservice if it's a negative result, whereas we may have missed something. So we would first have to assess whether the specimen is adequate. And then once we do that, we can interpret it. So once we interpret it, then we can tell the clinician, look, this is a negative pap smear. Your patient has no abnormalities within the epithelium, or it is a pap smear with epithelial cell abnormalities, either it be squamous cell abnormalities or glandular cell abnormalities. And then we pick up other things within the cervix. If there may be other neoplasms, hematolymphoid neoplasms, melanomas, other specific pathological entities within the cervix, we can report that as well. And then additional notes that we also add sometimes are sort of recommendations and guidelines. Obviously, that comes with the specific entity, so the obstetricians and gynecologists and how they specifically manage their patients based on the result of the pap smear. So we sometimes do give recommendations and guidelines in our report. In terms of the specimen type, the conventional pap smear, as I said, is the age-old method of collecting the specimen sample and submitting it to cytopathology for assessment. And this has been used since the inception of pap smears. You take the sample using the wooden spatula, smear the slide that you have with it, and fix it immediately with the alcohol fixant. This is the method. Once you've done that, you submit it off for assessment. That's the conventional way of doing things, and that's what most people may have been using for a very long time. In terms of the liquid-based cytology, this is now the future, and this is the new way of collecting pap smears. It's not very new, but it's not used as commonly as the conventional pap smear, and we would like to encourage usage of liquid-based cytology, and I'll give you a few reasons why. So liquid-based cytology, there are two sets. You have the thin prep and the sure path, and they're similar, and they're similar kits, and they're provided to the clinicians, the obstetricians, gynecologists, and within the kits you've got what you need to collect the sample. And collecting the sample is similar to your conventional pap smear. It is using the instrument, the brush, collect the smear, and instead of smearing it over the slide like we did with the conventional pap smear, you now rinse it in a specific vial which has a preservant, methanol for the thin prep, and then once you've rinsed it, you submit it to the lab, and I won't get too technical with that because it's now the machines do all the work. So in terms of what happens between the time that you submit it to the time that we get the slides, it's machine based, and the machine eventually produces a very well put together slide for us to have a look at. And with the sure path, it's a similar procedure. It's just that instead of rinsing it in the vial, you snip off the brush, submit it into the vial, close it, and then send it off to the lab. So that's the method of collection. Nothing too strange, nothing too difficult, but the results can be vastly different. In terms of specimen adequacy, we have to assess, or do we have an adequate specimen that's adequate enough to assess? We look at the squamous cells. In the conventional smear, we need about 8,000 to 12,000 squamous cells, whereas with the liquid-based cytology, we need about 5,000 squamous cells. And the reason, we need fewer cells with the liquid-based cytology, as I'll show you now in a few illustrations, is because of the way in which the slide is made and the way in which cells are smeared across the slide. With the conventional smear, you are smearing the entire slide with the material, and it can be smeared thickly or thinly. And I will show you an illustration to better understand what we mean by the number of squamous cells, and we need to be able to make an adequate diagnosis. In addition, we need to be able to see, do we have transformation zone or not? Transformation zone just lets us know if you are if the specimen is adequate, because in that transformation zone, we know that that's where most of the pathology starts. So if we don't have a transformation zone, we can't say that it is a representative sample. The other thing is, are there any obscuring elements? Obscuring elements such as blood, inflammation that sit over the squamous epithelial cells that prevent us from assessing them properly. With all this being said, if there are any atypical cells on any smears, regardless of whether there are enough squamous cells or whether the transformation zone exists or whether there are any obscuring elements, we would report that as an atypical smear. So we would not report that as inadequate. And these illustrations just show you what I mean by unsatisfactory. So on the top left, that's LBC, an LBC smear, which is unsatisfactory. And the reason for that is there are just too few squamous epithelial cells. We do have endocervical cells, which is representative of the transformation zone, but we can't assess the squamous cells adequately because there are just too few. So we would have to send that out as unsatisfactory. Whereas the one on the right is satisfactory. There are numerous numbers of squamous cells, although atrophic, and that's good enough. There are enough squamous cells, and hopefully we would see a few endocervical glands to let us know that that we are in the transformation zone and that this is representative. And at the bottom is an unsatisfactory smear. This is a conventional smear, and it's unsatisfactory because the smear is thickly smeared and it's inflammatory cells only. So we can't see what the squamous epithelial cells look like underneath this, which limits our attempts at accurate diagnosis. So we'd have to convey that message to the clinician to say, look, we did receive a smear. Adequate. There are a lot of cells. However, the actual squamous epithelial cells, which is what we would like to assess, are obscured by inflammatory cells, and therefore we cannot assess it accurately. So once we've decided that it is an adequate smear, we would interpret it, and the interpretation comes in the form of is there or is there not an epithelial lesion? So negative for intraepithelial lesion or malignancy, there is no epithelial lesion. So we've assessed the smear and it is negative for a squamous or glandular lesion. That doesn't mean that there are no other pathologies. We can have fungal elements, other microorganisms. You can have other lymphocytic cervicitis. There are so many other things we can report on, but what it really just means is that this patient does not have any intraepithelial lesions in the cervix. Moving on to epithelial cell abnormalities, we divide them into either squamous or glandular. So I'll discuss the atypical squamous cells of undetermined significance and the ASC-H lesions a little bit later. But there's that atypical category, which we use when we're not sure whether we're dealing with a low-grade lesion or a high-grade lesion, or whether we think that the lesion is endocervical cells or ectocervical or endometrial cells are atypical. So we would, with the squamous cells, we would tell you if it's atypical squamous cells of undetermined significance, it means, it could be a low-grade cell, but we're not sure. So we err on the side of stepping back. With the ASC-H, it could be a high-grade lesion, but also we're not sure. And I'll just explain that a little bit later. In the glandular component, when we see atypical glandular cells, we do try to let you know where it's coming from. Do we think it's endocervical or it's endometrial? So we would tell you, just so you know which way to move forward in terms of your management of the patient. Then there's low-grade lesions, also, which encompasses HPV and your cervical intraepithelial neoplasia grade 1 lesions. And then if there are atypical atypical glandular lesions, but we really suspect that this may be a neoplasm. We would tell you we favor a neoplastic lesion, and then you can correlate clinically and see whether you agree and whether you how best to manage your patient. And then there's the high-grade squamous lesions and the endocervical carcinoma and adenocarcinoma in situ, and then your invasive lesions, which is your squamous cell carcinoma and your adenocarcinoma. So once we've interpreted it, we would let you know this is what it is. It's an L cell, it's an H cell. If there are any other issues or if there's anything else, we would report it, and we would sometimes give recommendations. Now, the ASCUS and ASC-H component of the Bethesda system was the initial category was ASC, atypical squamous cells. That was the initial category. And obviously that was there was a lot of discontent from clinicians, because what does atypical squamous cells mean? What do we do with the patient? So they went back, revised the Bethesda system, and split up that group into the ASCUS, which is atypical squamous cells of undetermined significance, and ASC-H, just to help clinicians see where exactly the patient is sitting. So ASCUS more towards ulcer, as I explained before, as you can see on the left. It could just be you have a smear full of normal cells and perhaps one cell looks like an ulcer, but you cannot really commit to it yet. And that's when we would use that ASCUS. You don't have enough proof to say that this is a low-grade lesion, but you have a suspicion based on one or two cells with where the criteria isn't fully met for an ulcer. Whereas with the ASC-H, it's a similar thing. You have a low-grade lesion with maybe a few cells, a couple, one or two, where you think it may be a high-grade lesion, but you're also not sure and you don't want to commit because it's one or two cells. You can't prove that this is definitely a high-grade lesion, but you want to convey the message to the clinician that, look, I suspect something. Therefore, you call it an ASC-H. Now, this category, each lab has to monitor their quality assurance rates with this, because you can't use too much ASCUS and ASC-H in your diagnosis. It doesn't help the clinicians. So with that, each lab has to go through quality assurance and check for their ASCUS and ASC-H rates. So you need an atypical squamous cells to cell ratio. Those are one of the things that we use to assess whether the labs are overusing the specific category. And the other one is atypical squamous cells to high risk HPV positivity rates. The higher the rates, obviously the labs would need to assess what's going on, and would need to pull back on using this ASCUS and ASC-H diagnosis, and try to commit to one of the other diagnoses to better help the clinicians manage their patients. So back to liquid-based cytology, as I explained, the method of collection is similar. It's prepared in the lab, and we get the slides are given to us to assess. Now, before they were approved by the FDA, a few categories or criteria were used to assess whether this is indeed something that would improve cytopathology. And indeed, they came to the conclusion that yes, the liquid-based cytology seems to have properties that would make cytopathology and the reporting of cytopathology and the making of picking up specific diagnoses. It improves all of that. It improves the specimen adequacy as well. So fewer inadequate specimens, which is great because clinicians don't always want to go back and retake smears. So that from a clinical point of view, is really helpful. And also, it's improved the uptake of picking up pathologies. It's improved the uptake of picking up your low-grade cells, your high-grade cells, and your ASCUS, and again, decrease the rate of unsatisfactory smears. And this is just an illustration of liquid-based cytology on your left, and on your right, on your left is conventional pap smear, and on your right is liquid-based cytology. And basically, just to illustrate why liquid-based cytology is better at assessing, at picking up morphologies, as well as fewer unsatisfactory smears. Because on the left, so many things can go wrong. Once you smear, you either smear too thickly and then we can't see the epithelial cells, you smear too thinly and then you may not have enough cells there. Whereas with the liquid-based cytology, all the guesswork is taken out. You just rinse whatever brush you've used, and then the cells are collected and then processed. And we get a nice thin monolayer of cells where we can see the morphology very nicely, and we're able to assess the cells so that we're able to give as accurate a diagnosis as possible. So that's one of the very big advantages of liquid-based cytology. The other advantages, because now it's in a vial instead of a smear, we can do so many other things with it. We can prepare duplicate slides and cell block. Cell block just gives us a little bit more of a histology aspect to cytology. In case we would like to see more of the architecture of what we're looking at instead of just the cellular structure. It also provides the substrate for further HPV testing, as well as automated screening devices, which is off the back of liquid-based cytology, and I'll just touch on that briefly. And then, like I said, it reduces the number of unsatisfactory specimens, and also less tiring for us to look at, because you have a nice thin monolayer of cells. You can look at the cells. A smaller portion of the slide is utilized, and that really does help. It also reduces the number of false negative test smears, because fewer obscuring artifact, so you basically have every single cell in full view for you to have a look at and assess. And I said it increases the detection of pathologies. And then lastly, just briefly, automated screening. I mean, this is really the future of cytopathology, and it's off the back of liquid-based cytology. Basically, what it is once the slides are prepared using the method of liquid-based cytology, they're fed into a machine which then screens the slides for you, and then comes up with a certain number of fields of view for everybody, for those cytopathologists to have a look at. And once it's marked those specific fields of view, those fields of view basically are areas that the machine, once it has all its algorithms put in, those fields of view are basically what the machine thinks is relevant for the pathologist to have a look at, based on cellularity, the type of cells, the what components are in that specific view, the shape of the nucleus. And so once that's done, the cytopathologist looks at those specific fields of view. And if it's fine and there are no abnormalities, that slide passes as negative. However, if any abnormalities are picked up, that slide will then be pulled out and manually screened. So that also, cuts down on screening time for cytopathologists, so that more time is going into each and every single slide, and it's just a little bit more accurate. So this is really the future of cytopathology. We've come from the conventional pap smear, which at its inception was great, but now we've improved on that, bringing in liquid-based cytology, and hopefully in the near future automated screening will come into play as the new kid on the block. And with that, I thank you for listening to my talk.
Well, thank you very much, Amanda. Thanks for that informative talk. I think without any further delay, I want to ask Dr. Naidu in Durban to continue with her talk that will deal with the interesting topic of HPV infections and molecular typing. So go ahead when you are ready, Vaneshri.
Thank you so much, Dr. Pete. Thank you to everyone for joining us this evening. I'm Vaneshri, and I'm going to be discussing human papillomavirus testing as part of cervical cancer screening. There are over 100 types of human papillomavirus. More than 40 of these genotypes infect mucosal surfaces. In terms of female reproductive health, the important sites are the cervix, vagina, and vulva. we have sufficient evidence to risk stratify HPV genotypes into oncogenic high-risk types and non-oncogenic low-risk types. This table shows us the 14 high-risk types and the 11 low-risk types. The high-risk types contribute to the development of cervical cancer, and the low-risk types are associated with benign or low-grade lesions and genital warts. As an anatomical pathologist, HPV 18 and HPV 45 are associated with the development of adenocarcinomas of the cervix, while the rest are associated with squamous cell carcinomas and other variants. Primary screening for cervical cancer. So I think it's important to understand the function of a screening test. A screening test is done to detect potential disease in people who are asymptomatic. I think we must stress that screening is for asymptomatic patients, and I'm going to discuss screening in this talk. Should a patient have symptoms, should they have pervaginal discharge or pervaginal bleeding, those patients fall away from the screening algorithm. Those patients require clinical examination, diagnosis, and treatment. So screening is to detect disease in a wide number of patients who are asymptomatic. The goals of primary screening are early detection so that we can provide early, effective treatment. There are primary screening options that are available to us, and they include high-risk HPV DNA PCR testing and cytology. Cytology can be the conventional glass slide for pap smears, or, as Dr. Egan has discussed, liquid-based cytology, which is the future. Of note, HPV vaccinated women still require screening. This is because the HPV vaccine doesn't protect us against all types of HPV causing cervical cancer. So despite the vaccination status of a woman, she still requires screening. This is a very useful guideline published in the Journal of Gynecological Oncology in 2017. These are our most recent guidelines for cervical cancer screening in South Africa. I thought this was quite a good article because it accounts for the diverse healthcare landscape that we have in South Africa. It accounts for whether you are in a low resource setting or a high resource setting, and it provides options for practitioners based on their setting. The guidelines say that both HPV testing and cytology are suitable as primary screening methods. However, the guidelines recommend migrating to HPV primary screening as soon as it is practical. The advantages of using HPV testing as a primary screening tool is that HPV testing has a higher sensitivity in detecting precancer and cancer compared to cytology. Another advantage is that it has a better negative predictive value compared to cytology. This means that with HPV testing, we can safely lengthen the screening interval. So if a patient tests HPV negative, she only needs to be screened at a 5-year interval. This is in comparison to a 3-year screening interval for negative cytology. Another advantage of HPV testing, which I will touch on a bit later, is that self-collection of specimens is possible. This makes this accessible to many patients who are unable to attend healthcare facilities for various reasons. Any test has limitations, and the limitation of HPV testing is that it is poorly specific. HPV testing does not tell us whether an infection can be cleared spontaneously from those infections that persist, leading to precancer or cancer. If we have to compare the two methods of primary screening, HPV testing versus cytology, HPV testing has high sensitivity and cytology has high specificity. A negative HPV test is more reassuring than negative cytology, as cytology has a higher incidence of false negatives. However, cytology also assists us in detecting other pathology within the female genital tract, such as endometrial pathology. HPV testing does not allow us to detect such. This is a table illustrating what tests can be done on what specimens. So the first specimen is liquid-based cytology. This targets the cervix. The sample is collected by a healthcare worker, and tests that can be performed on liquid-based cytology are both HPV testing and morphological assessment of the cells on cytology. Conventional smears are also collected by healthcare workers. The cervix is targeted, and only cytology can be performed on a conventional smear. HPV testing cannot be undertaken. If we have a flocculated swab self-collected from the vagina of a patient, only HPV testing can be performed on the swab. We cannot assess cytology on this specimen. AMPATH offers high-risk HPV PCR testing with partial genotyping. This means that we can identify HPV-16 positive patients, we can identify the group that is HPV-18 positive, and then the other high-risk types, which have a much lower incidence than the 16 and 18, are grouped together. In terms of costing for HPV DNA testing, AMPATH, the test currently costs 560 Rand, and there is a 20% cash discount, which makes the test 450 Rand. Since I'm talking about cost of testing, there's often a misconception that liquid-based cytology is a much more expensive test than conventional cytology. And when I checked the pricing, liquid-based cytology is actually only 10 Rand more expensive than conventional cytology, and both the tests with AMPATH have a 20% cash discount. This is quite a busy table taken from the South African guidelines published in 2017, but it's quite an informative table. And as I said, the guidelines allow for adaptability and flexibility depending on the resource setting, whether low resource or high resource, so public sector versus private sector. It's important for us to know the HIV status of our patients because it leads to different screening algorithms and different intervals of screening. The recommendation is to initiate screening at age 25. And in the HIV positive population, screening should be started at diagnosis of HPV. Exit of screening from the cervical screening program should be at age 55 in a low resource setting, or at age 65 in a high resource setting, or when the patient has had a total hysterectomy. Importantly, in HIV positive patients, screening should not end. These women should be screened for their lifetime. I'll just look at the high resource setting, and the South African guidelines will say that cytology is an appropriate primary screening tool. If cytology is used, if the patient is HIV negative, they should be screened 3 yearly, and if the patient is HIV positive, they should be screened annually. If we use HPV screening, in HIV negative patients, the screening interval is 5 yearly, and in HIV positive patients, it is 3 yearly. The difference between high and low resource settings is that in low resource settings, the intervals are increased for screening. The time intervals are increased for screening. This is a lovely flow diagram put together by our virologist at AMPATH, one of our virologists at AMPATH. This is from Dr. Marcel Myberg. And it's a helpful table in stratifying the risk of our HPV HPV positive patients. If we look at the top blue block, we will do the primary screening test, being the HPV test as recommended by the South African guidelines. If the patient is negative, they follow the green or low risk pathway. They continue screening at the interval appropriate to them, depending on their HIV status. If the patient tests positive for types 16 or 18, which are the high-risk types, we will follow the red pathway. If they are HIV positive or older than 35 years of age, they are high risk, and they should receive treatment immediately. And then they are followed up yearly. If now we're looking at the middle yellow flow pathway, if they test positive for other high-risk genotypes other than 16 or 18, they are deemed medium risk. In these medium risk groups, it is recommended that they are triaged with cytology. This can be LBC or conventional cytology. The triage is put in place to avoid overtreatment or undertreatment of these medium risk patients. If the cytology is abnormal, they are treated and followed up yearly. If the cytology is normal, they followed up annually. HPV self-collection is an up-and-coming method. This is a watch this space with AMPATH. It's targeted for use in underscreened women who lack access to healthcare facilities. But studies have shown that screening coverage can increase in both high and low resource settings. A kit is provided to the patient. The kit contains a highly absorbent flocculated swab. The patient uses the swab to swab the vaginal wall. Studies have shown that self-collected samples and clinician-collected samples are showing equivalent sensitivity for HPV testing. AMPATH is currently piloting HPV testing self-collection kits, and this is a watch this space. There will be more information on HPV testing and self-collection to come. This diagram just illustrates how self-collection is done. The patient uses a very absorbent swab to swab their vagina. They insert the swab into the vagina till an indicated mark. The swab is rotated 1 to 3 times. The swab is removed and inserted into the tube and returned to the lab. It is a quick, painless, easy, effective way of testing for HPV. This is not a test for cytology. It will only tell us HPV status. So my key points from this talk is, according to the South African guidelines, both HPV testing and cytology are both appropriate primary screening tools, but it is advised that we migrate to HPV primary screening as soon as it is practical. It is also important to differentiate between our HIV positive patients and our HIV negative patients because they have different screening intervals. And self-collection for HPV testing is an up-and-coming method. I just want to really acknowledge my colleague, Dr. Marcel Myberg, who is a virologist with AMPATH, for providing much input for my talk, to our AMPATH librarians for helping me source information, and to my co-presenters. Thank you so much for your time.
Right, great talk. Thank you, Vaneshri. We've got one question that was actually quite interesting. The question was, can we recurrence rate of LSIL in following lead specimens? And I think the only comments that I really want to make is that you must understand that LSIL, I would say in concept, is an HPV infection. And quite often, if you get a recurrence of LSIL, it's probably just a reinfection. And I think that's the best way to explain that. I cannot tell you exactly what the incidence of this will be, but we do see it all the time. The other thing is also that you must understand that histology is sometimes not entirely accurate in terms of reporting the margins, especially in piecemeal specimens. So one should always probably read the histology report with a bit of caution when we say that the margins are clear, especially with low-grade lesions. Remember, it is an HPV infection, and it is almost by definition a multifocal disease in the lower female genital tract. Are there any other comments from the panel on that particular topic? Happy. Well, it's wonderful how we filled up the hour. It's actually quite amazing how quickly the time went by. So there's only one thing that remains. We have a national network of pathologists that are just eager to assist you with your diagnostic needs. So on behalf of the Ampath family, I want to wish you all a wonderful evening, irrespective of your local load shedding schedule. And most importantly, stay safe. Goodbye.